Hospital. She also obtained accreditation postgraduate diploma in both midwifery and critical care in the military hospital. Her role expanded to be a CNO in the first cluster hospital in the Ministry of Health and led the transformation program for 2030. Welcome on stage, Dr. Moahab.
It's a big pressure to follow all these good speakers. Thank you very much for inviting me here, Ms. Hera and Musa's group. I was extremely impressed when I visited your hospital 2 months ago, I think it was. I think we need to just clone you everywhere in the kingdom. Today, I'm going to talk about value-based nursing. And the reason why I'm going to talk about that is because as a young nurse, I was very fortunate to have mentors and practiced in Magnet Hospital in the United States for 21 years. Then I moved to Saudi Arabia. And I actually can tell you I grew up more in Saudi than I ever did or would have in the United States. I had the opportunities to be part of designing the transformation efforts in the healthcare, and now had the opportunity of leading the military system and establishing a nursing army. So, value-based nursing. As a definition, what is value? Value is to give the best care possible with the best outcome in a conscious, financially conscious way. This morning we talked about values. We talked about Magnet, right? So value-based, when we give excellent nursing care or excellent health care, and we see our patients improve, all of us as clinicians need that to continue practicing, because it gives us the satisfaction that we need to fulfill the calling that we went in for healthcare for. There are many stakeholders to value-based. The society as a whole, if we practice this, benefit because we'll spend less on healthcare. And if we spend less on healthcare, there'll be more money left over for roads, for education, for other programs. For the patient, if the patient is paying out of their pocket, or if their insurance is covered, they will pay less if we provide good care with good value. The provider, like I said, it's higher satisfaction rate. And for the payers, they will love us because we will only keep patients the amount of time that we need to keep them in the hospital and get them out when needed. For the suppliers, we tell the suppliers what are the best supplies do we need to get the best outcome. So I'm going to go back a little bit to healthcare as a whole. So we know until now, since the very famous movement of 1999, that patients are getting harmed every day. 1 in 10 on the average get a medical error, right? In developed country, about 5% of the deaths are due to preventable healthcare mistakes. In lower middle income countries, it's way worse. 1 in 4 get harmed. And 1 in 24 dies. Those are very alarming numbers. And they have an impact on the whole society. They have an impact on the economy. So, how much do we really spend? As I grew older, I became more and more friends with the CFOs that I work with, because we learn to speak the same language, to get resources and make them understand. I remember in one of the hospitals that I worked in, we wanted a certain project, and the CFO said, no, we don't have that money for that budget. Then I told him, come with me, let's do rounds. We went in the hospital, we did the rounds. By the time we went back to his office, I got the money. So you get to involve the decision makers. So in Saudi Arabia, we spend a lot of money, not as much as some other countries, but we spent 7.82% of our GDP last year. It is not as high as some of the countries like United States, but it still went up by 59% over the last decade. What is this telling us? Healthcare costs is going up in the country. And every single nurse, even if you're a bedside nurse, you have to be aware of the cost. So there's always a talk in the board meetings. When we're looking over at the budgets, we look at, okay, so where can we cut? And guess what? Nursing. They always look at nursing. Where can we cut? Let's look at the largest number in the hospital. Can we cut their staffing? Nurses, they don't bring the patients in, so we consider them as an expense, not as making money for the hospital. Also, the representation of nursing is very low in the boards. Dr. Hiba a little while ago was talking about the need to increase the representation at the board level. I couldn't agree more. We need that voice at that level. And also, it is our fault as nurse leaders that we did not highlight the value of nursing in dollars or in reals. That's what we need to do. We need to show what do we bring to the table. If we have the proper nursing staff, not only in numbers and not only in capabilities, but also in the autonomy that we give the nurses. So it is our role as nurse leaders to do that. And when I was a young nurse in the ICU, I was very focused on clinical outcome and patient safety. And as I grew older and a little bit wiser, I said, I must add money to my talks. So nurses are always the target when it first comes to reducing the numbers. I hear all the time, why can't we just take all the nurses out of the clinics and have nurses' aid run the entire clinics? It's a thought, but it's not entirely correct. We do need nurses even in the primary care. So this is the average cost, the average turnover. In Saudi Arabia, the turnover, Dr. Muhammad this morning was saying about 17%. Yeah, that is about this study that showed that the cost of 16.5% yield in estimated loss of 4 to 6 million. We also know that if you increase one full-time nurse to every 1,000 inpatient, mortality decreased by 4.3. Each time that we're short on nurses, mortality increases in the ICU 2 to 7%. 46% of the nurses, they admitted to making medication mistakes. We all had medication mistakes. I think that number is very conservative. So we need to talk in this language. We need to define where possible and quantify the economic value of nursing and midwives. The return on the investment is what we need to make very clear, not only to the nursing societies, but also outside the healthcare. I think we need to involve decision makers outside the healthcare to make the work of nursing and the healthcare better. We know that when we have poor staffing, we have increased mortality rate, increased morbidity rate of all kinds, and increased length of stay. also in 2014, the midwifery, the World Midwifery, they looked at 83% of all maternal deaths can be prevented if we had good midwifery care. And that most women really do not need physicians when they're pregnant because they're healthy individuals. And midwives can take care of them. So if we know these facts, and we know that if we get midwives and probably trained nurses will have decrease in preterms and decrease in unnecessary C-section, the amount of saving for the society, for the hospital, is huge. Each day a preterm baby spends in the NICU costs at least about 10,000 riyals here. It can go up to 30,000 in the NICU. So investing in midwife education can actually do a return of investment 16-folds. What does that mean? That means if I educate more midwives, I will save all the money that we shared before. So if I tell you, if you put your money in some bank that will give you 16 folds, are you going to put your money there? Of course you will. But here we have the research, we have the evidence, and we need to let the decision makers in the government know this so they can increase the number of schools of nursing. Instead of only having 3,800 nurses graduate, we do need about 11,000 nurses each year. So, while we make up the largest number of workforce, the investment in our education is only 25%. How many times do you see a physician come back, Saudi physician come back from consultancy in Canada, where they spend good amount of years in the United States or in Canada to learn? How many nurses do we have that we send for scholarship? Definitely nothing equal to that. In Bahrain, which I really was very impressed, in Bahrain at certain point, in the Ministry of Health, they used to have Dr. Fatma Abdul Wahib, who's just retired now, and she was the head of the Human Resource and Finance at the same time. So whenever she gets a physician application for scholarship, she used to say, go find your counterpart of a nurse and we'll send you. So the physician would go and tell the nurses, hey, do you want to specialize in cardiac ICU? So something needs to be done to invest more in nursing and midwifery educations. And I don't know if we have any midwives here. Yes, I love you. They are orphans. Midwives are orphans. We need to adopt them because they don't have that voice. So nurses and midwives are the heart of the healthcare. So I thought I'd share a local case with you. I just did a presentation to Minister of Defense not long ago. And we estimated during the COVID year, 2 years, we had lost 2.2 billion across the 25 hospitals from nursing shortage. We calculated everything. We calculated turnover, we calculated CLAPSIs, we calculated CAUTIs, we calculated injuries, we calculated increased length of stay, and it was 2.2 billion. Had we had all the nurses, every single position filled at that time, we would have spent 1.5 billion. So 700 million lost because we didn't have the nurses. So this is a very dear hospital to my heart that I worked in, and it's a small hospital, but we decreased, as you could see, the cases of of CLABSI by going through the magnet journey, and we were able to sustain it to 0. That resulted in 2.4 million estimated saving. And this is the reduction in CAUTI was about 623,000. For those CNOs who are going through magnets, it would be nice if you're in your town hall meeting, the hospital-wide town hall meeting, quarterly, if you can present the savings in dollars or reals. Then you get everybody's attention. So that was the total amount of savings that we had in that particular year. I'm just sharing this picture with you because in 2019, Saudi Arabia hosted the Ministerial Summit. In that Ministerial Summit, something was born, which we will discuss later on in the leadership meeting. The idea of safe staffing was born. And to me, that is a historic day that continue to affect the way healthcare is conducted in our country, because from that day started a white paper that we wrote with some of our colleagues. Dr. Ilham is sitting right there. She was one of the co-authors of that paper. Then recommendation went up to the safety center. They adopted it. Then it went into our legislative body, Sabahi, and it's going to come out in the next chapter, the next book to 2023. There will be mandated safe staffing in Saudi Arabia. So I always refer back to the ANA. It's like everybody has a little Bible. That's my little Bible, ANA. Only by determining the economic value of nursing to patient, healthcare organization, and cooperation will the profession be able to capitalize on the contribution to its healthcare quality and overall healthcare and well-being of the society. So Dr. Hiba, again, I'm going to refer to her, had called for attention and mentoring of the leadership. I second that, but I also add, let's concentrate. Instead of only talking about patient safety, let's talk about value-based nursing service. Thank you.